right, welcome colleagues to The Explainer. Today we're diving into a virtual curbside consult on the absolute most prevalent neurological disorder you're going to encounter in your practice, the tension-type headache. Look, if you've spent even a single week in a primary care clinic or a neurology ward, you've seen this. But today, we're moving way beyond the basic textbook definitions. We're going to truly unmask the pathophysiology, the diagnostic nuances, and the evidence-based management strategies that actually work for these patients. Let's start by picturing a classic presentation. Imagine a 35-year-old patient sitting right there on your exam table. They're fatigued, they're stressed, and they're frequently visiting your clinic describing this dull, non-pulsating, vice-like grip on their head. In fact, they'll usually say something like, "It feels like a tight, heavy band squeezing around my head." That right there is the absolute hallmark of our case today. And this isn't just some rare anomaly or a minor inconvenience. An astounding 86% of the general population will experience this at least once in their lifetime. And the peak incidence hits right in that 30 to 39-year-old demographic. Think about it, that's the core of our active workforce. So the societal burden, the lost workdays, the economic impact of decreased productivity, it's just massive, even if the individual attacks themselves are mild. Here's our clinical pathway for today's session. We'll go through the clinical presentation, red flags and differentials, unmasking the pathophysiology, the ICHD-3 diagnostic criteria, acute management and pitfalls, and finally, preventive and behavioral therapies. Okay, section 1, the clinical presentation. So let's dive right into what this looks like when you're taking the history. The classic presentation is a bilateral dull ache. It's usually mild to moderate. Now, a really key distinguishing factor to ask your patient about is physical activity, because unlike other primary headaches, a tension-type headache doesn't worsen if they say climb a flight of stairs or walk around the block. There's no severe nausea or vomiting. And clinically, when you do your physical exam, you'll frequently find increased pericranial muscle tenderness. If you palpate the frontal, temporal, and trapezius muscles, you'll often find these tight, hyperirritable trigger points. Moving right along to section 2, red flags and differentials. Before we confidently stamp tension-type headache on the chart and just send them on their way, we have to play Sherlock Holmes. We need to rule out the dangerous mimics. If your patient presents with any of these red flags, you absolutely need to hit the brakes. We're looking out for that sudden thunderclap onset, systemic symptoms like fever or unexplained weight loss, or any focal neurologic deficits or papilledema on your exam. A huge one is age. If a patient is over 50 and presenting with a brand new headache, or if their usual headache pattern suddenly changes or becomes positional, well, you just can't assume it's tension. These are the critical moments where you order neuroimaging, like a contrast MRI, to rule out secondary headaches, brain tumors, or vascular issues. Now, you might be wondering, what's the most common clinical pitfall? It's misdiagnosing a mild migraine as a tension-type headache. Remember, tension headaches are bilateral and pressing. Migraines, on the flip side, are typically unilateral, they're pulsating, and they come with debilitating nausea or extreme sensitivity to light and sound. A lot of patients who show up in clinics with disabling tension headaches actually have migraines without aura, so you really must probe for those specific migraine features. All right, section 3, unmasking the pathophysiology. Let's look under the hood to understand exactly why our 35-year-old patient is experiencing this persistent band-like pain. We used to think this was just a simple muscle contraction issue, but the reality? It's way more complex. The crucial mechanism we need to grasp here is central pain sensitization. In chronic cases, the central nervous system becomes highly reactive and hyperexcitable. The brain essentially cranks up the volume dial on pain signals. Patients literally develop a lower threshold for pain, which means completely normal signals are misinterpreted by their brain as noxious, painful stimuli. So let's trace how this builds into such a vicious cycle. Step 1 starts out in the periphery. Things like stress, poor posture, or lack of sleep activate the myofascial nociceptors. That's the pericranial tenderness you feel on your exam. Step 2, this creates a continuous stream of nociceptive input traveling from those peripheral structures straight to the spinal and trigeminal levels. And then, step 3, this persistent bombardment actually rewires the central nervous system. It creates hyperexcitability and decreases the brain's natural descending pain inhibition. Basically, a localized peripheral problem transforms entirely into a central neurological issue. Which brings us to section 4. ICHD-3 diagnostic criteria. With the mechanics understood, let's pull out the official blueprint we use in practice. We categorize the disorder based strictly on frequency, and this is vital because it directly dictates your treatment strategy. Infrequent episodic means less than 1 day a month. Honestly, most of these patients never even make it to your clinic. Frequent episodic is 1 to 14 days a month, and chronic, that's 15 or more days a month. Notice that in the chronic phase, the duration can be totally continuous, stretching from hours to days, and they might even develop some mild nausea. Having the patient keep a headache diary is absolutely your best tool here to get an accurate count. Section 5. Acute management and pitfalls. Okay, so our patient is sitting in front of you with an active, frequent, episodic headache. What's the immediate action plan? For acute management, simple, effective analgesics are our front line. Ibuprofen at 400 to 600 milligrams or naproxen sodium at 220 to 550 milligrams are highly effective. If NSAIDs are contraindicated for any reason, use a proper 500 to 1,000 milligram dose of acetaminophen. The golden rule here, treat early after symptom onset. Don't let them wait for the pain to peak. And crucially, we must avoid opioids and barbiturates entirely. There's just no way around it. They lack superior efficacy for this condition and introduce immense risks. Now, here is a critical warning, and it's a place where primary care can inadvertently cause a lot of harm. It's the ultimate irony, really. Treating the headache can actually cause the headache. If you don't counsel your patient properly, they might just start taking over-the-counter NSAIDs every single day. Taking simple analgesics for 15 or more days a month will trigger a severe medication overuse headache. You're essentially trapping them in a rebound cycle of pain. You absolutely must cap their acute usage to less than 15 days a month. And that leads perfectly into Section 6, Preventative and Behavioral Therapies. This is the most challenging yet rewarding phase of our consult. What happens when acute therapy just isn't cutting it anymore? Or the headaches are hitting more than twice a week? When capping those NSAIDs leaves your patient miserable or their disability is severe, you can't just keep throwing abortive meds at the problem. We have to shift our clinical strategy from reactive acute treatment to proactive preventative management. Our stepped approach begins right at the foundation, identifying and managing lifestyle triggers. We're talking poor sleep, unmanaged stress, bad posture at their desk. Next, we highly recommend initiating behavioral therapy. Biofeedback combined with relaxation therapy has incredibly strong evidence-based efficacy. It literally trains the patient to consciously lower that pericranial muscle tension we talked about earlier. Only after or alongside these steps do we move to step 3, which is prescribing targeted prophylactic pharmacotherapy. When we do cross into pharmacotherapy, amitriptyline, which is a tricyclic antidepressant, is our absolute gold standard. But here's the real art of prescribing it. You've got to start low. Give 10 to 12.5 milligrams nightly and titrate up very slowly, as tolerated, to a therapeutic dose of up to 100 or 125 milligrams. Make sure you educate the patient that we're using this for its independent pain action and peripheral anti-nociception, not necessarily for depression. And clinically, this is a non-negotiable rule. Always grab a mandatory baseline ECG for patients over 40 to check for cardiac conduction issues before starting. As we wrap up this clinical round session, I want to leave you with a final, somewhat provocative thought. Are we just acting as a dispensary for temporary pain relief, or are we taking the time to address the complex web of lifestyle factors, stress, and central neurological sensitization that is actually driving our patients' pain? Mastering the tension-type headache means looking way beyond the simple analgesic prescription. It means treating the complex, whole patient sitting right in front of you. Thank you for joining me on this explainer, colleagues. Now let's take this knowledge straight to the wards and clinics.